Okay, can you see my slides?
Yes.
Okay. Hi, everybody. So this is, I guess, our second training, and they said I could do it on any topic I wanted. And so what I did is I said, what is it that we could teach everybody? Nurses, providers, case managers, anybody. So to me, addiction is real. It's in every part of our life. So we just thought we'd talk about how we can actually help our patients with opiate use disorder. I have no financial disclosures. So we have three main objectives today. It's identifying how stigma poses barriers to treatment, recognizes the way of stigma surrounds medications for opiate use disorder, and discuss ways to remove stigma to better treat patients. And so the first thing I want to say is this is a small group. We're all good friends. Don't hesitate to say, interrupt me, please. This is an open forum if you have any questions along the way or want to be able to do some discussions. For me, I want to make sure that medically everybody knows, even the people who don't do diagnosis, what the definition of addiction is. Because sometimes we have in our mind this old adage of just say no. We've been taught that by politics in the past, and we just have to kind of get out of that. Addiction is a disease. It is a chronic medical disease. It's complex, interacting among the brain circuits. It has a genetic component. It has an environmental component, and it truly affects everybody's individual's life experiences. So I want everybody to know that this is a real disease. Some people just feel like they just got to get tough. Not so. It is a medical disease. So I had a fellow, an addiction fellow who worked with me last year. And I said, you know, Dr. Farouk, can you find me summarize everything in our nation and to make an impact? So he came up with this particular slide. And I thought it was really good. So I didn't make the slide, but he did for me, that opioid crisis is over our entire United States. It is the first picture right there. It says, you know, opiates are love. Many of our patients don't have somebody to care for them. And so they turn to the drug for comfort, and it's what they know. The next one is a real life story in Burlington, Vermont. I don't know if anybody knows Burlington, Vermont. It's beautiful. It's very picturesque. And they had a huge problem in Burlington, Vermont. They kept losing all their bicycles. What happened? They had a beautiful field there. Patients with substance use disorder came to the field. They built their own encampment, but they needed to find money. They needed to find food. They needed to find drugs. So what did they do? They stole all the bikes in Burlington, Vermont, in order to support their habit. So the beautiful, picturesque Burlington, Vermont was still even significantly impacted by opioid crisis. The third is, these are three different individuals in New York who have Uber Eats, and apparently they have Uber cocaine in New York. They ordered cocaine and they did not know that the cocaine was laced with fentanyl, and all of them died. So my point of this slide is to say it is an opioid crisis. It is everywhere, from the beautiful scenic Vermont to the cities of New York. I like color slides once in a while. I want you to see that back in my day, 30 years ago, there was no such thing as fentanyl. We had heroin and only heroin. Now we have fentanyl. You can't even find heroin anymore. Heroin comes from a poppy seed that you have to grow. And if the fields are endangered by weather, the price of heroin, or you can't even get it. So that's why we're not using heroin, our patients, anymore. They're using fentanyl. Fentanyl is man-made. It's very cheap to make. And look, you just need a few little grains of it to actually be fatal or deadly. The manufacturers for the streets substances are getting pretty creative. They have all kinds of pretty pills. These particular pills are an opiate with fentanyl laced inside of them. What child wouldn't want to take one of those beautiful, pretty color pills? So we have to really work in many ways to be able to help our patients with addiction. This slide you may have seen before. Patients, addiction is a brain disease, as I said in that definition. People who haven't been touched by addiction with their brain have the ability to say no. They can say no to drugs, they can pass them by. People that have an addicted brain, not so. They have this, their ability to say no goes away, and their ability to say go is enhanced. So sometimes we say our patients just get tough and they can't. Remember in the beginning, we said we need to save lives. How can we save lives? When you have a patient who has an opiate use disorder, whether it's your patient, your brother, your child, your coworker, anybody who has an opioid use disorder, what we're recommending now is best practice is that you talk to your patients and get them in the right way to be able to accept medication. And if you can get patients on medication for their disease, like you put them on insulin for diabetes, if you get them on medication, excuse me, for their opiate use disorder, you can lower the overdose rate by 76%. You can eliminate or reduce emergency room visits by 32%. So medication works. The medications that we use for opiate use disorder could be methadone, buprenorphine, or the blocker naltrexone. So all three of those medications are the most common ones that we use for opiate use disorder. But now what we have to do is to talk the patients into taking the medication. And anytime you have a person who has an opiate use disorder, you want to make sure they have Narcan. Narcan is not a prescription anymore. You can go to any pharmacy, you can pick it up, you can use your insurance, but the STOP Act of July of 2023 says that providers need to be able to make sure that their patients get their Narcan for free. So the next slide here is one of my favorite slides. It says, some things never change. We live in a decadent age. Young people no longer respect their parents. They are rude and impatient, and they frequent taverns and have no self-respect. I see that sometimes in our culture today, but if you see the inscription here, it's on an Egyptian tomb from 3000 BC. So I want to know that things that were a problem before, some things never change. We need to change our way of treating our patients with substance use disorder. We have to, or we'll be doing the same thing 3,000 more years later. So we're going to talk, so that's like a quick overview of addiction, but now we're going to talk about stigma of addiction. The rationale is our society places us in expectations on individuals. And you can read that sentence. And what I want to say is there's a story behind this. We had a Christmas party, and there was a person who came to the Christmas party, and people in the party went to this person and said, hey, let's have a drink. And the person said, no, oh, come on, you can have a little one. The patient, you don't know what kind of trauma or what kind of life experiences that patient has, but it's a social norm to drink and now to use substances. It's such an environmental and is socially acceptable that it becomes a stigma that if that person at that party didn't take a drink, they were stigmatized. Oh, what's wrong with him or her? So we have to realize as we put the society, our expectations on individuals. And that impact of stigma filters through every aspect of your relationship with your friends, your family, even your primary care provider can be part of your addiction if you're not careful. When we went to Clinical Scholars, I remember learning a lot about stigma and learning about internalized stigma, that what you don't even know that you have stigma that you were raised with and was part of your environment when you were growing up. But if you can understand your own internalized stigma and ways to be able to manage your stigma, then you're going to be able to decrease harmful behaviors. And what I had to do at my office, I had to change their language. I had to change their concept of how to be able to handle. Even we were an addiction office, we still had to change how we spoke, how the nurses spoke to their patients, how the front office answered the phone, and even how counselors managed their patients to be able to have more healthy conversations with our patients to get rid of stigmatizing language, behavior. So, what is stigma? We've seen this before: housing, race, gender, sexual practices, appearances. Obesity is a big stigma for many of our people in our nation, medical conditions, social classes, and sure enough, substance use disorder. If a person is stigmatized, they often have low self esteem, loss of status, and they get distressed. And our stigma actually legitimizes discrimination. I use the story here of the phone rings. Hi, Marian. I got one of yours down in the emergency room. What do you want one of mine? Got one of your frequent flyers down in the emergency room. So already there is huge stigma on the emergency room. They call them frequent flyers. They're coming back over and over again. That behavior and that language comes across to the patient. They have low self-esteem. Why should I keep coming back if they're going to call me a frequent flyer? And then we work on trying to get them a place to go to, and the place maybe doesn't have any open beds, or their insurance doesn't cover them. And so they can't get the treatment. And that whole vicious cycle starts all over again. So from the very beginning, having the front office, even in the emergency room, deal with your patient is important. So because we are a small group, I take a break here. We've got some more slides to go through. But I wanted to know, what comes to your mind when you think about the term of stigma? Anybody have any thoughts?
Thanks, Marian. This is great. I think of judgment, and so not having a posture of curiosity, but really passing judgment. I think of people being uninformed, right? Like that maybe it's coming from a place of just not knowing or understanding. And then I think of equity and accessibility, because I think it can impact those two things.
And I think your point, absolutely. Understanding your own, like I said, your own internal. If you don't know and you're not aware of what you're saying or what you're doing, then you pass the judgment, as you said, even when you didn't know. So the next question is, what are some ways in which people may be stigmatized? We talked a little bit about that in the emergency room. Anybody wanted to add? Anybody else? Any other thoughts of how people can be stigmatized? I keep saying patients, and this is my medical term. Stigma is everywhere, not just in the medical field. And the next question is just a self-reflection. Is take time to think about someone who may have imposed a stigma upon you. How did that make you feel? Because it goes both ways. You may have been stigmatized and it didn't feel well. So when we stigmatize other people, they don't feel well and they have thoughts about it too. Anybody had any thoughts about how they've been felt stigmatized?
So Marian, one
yeah.
area that we deal with a lot is with social media and the stigma that comes with the digital world. And I think there are generational gaps that we have not focused on as to how we can connect a little bit better with our younger generation and how we were raised, and then how the digital world communicates to us now, and how powerful that is with how we engage or don't engage, and how we use the digital platform to perhaps promote stigma or overlook stigma. So I think it's an area that's quite a challenge for us.
I didn't think about that one too, but you're absolutely right. Stigma is social media. It's not just a patient face-to-face, it's digital. I think AI is going to impact us too. Thank you, Hope.
So when I think of stigma, I think about a more macro perspective in terms of the majority community having a set of norms, and that those who go against those norms are ostracized or stigmatized, right? And as providers, one of the things, not even just providers, as people, being able to think through how we accept other people the way they are and accept people as they come to us allows us to begin to cut through some of the stigma. You know, back when I first started to practice, and I'm old, if a gay person came to our practice, there was stigma, right? We don't even think about that. I mean, in general today. So I think as societal norms change, our the way we think about others changes. But I think in terms of my own personal behavior, it's really how I accept everyone who comes to me as an individual. And they bring with them whatever they bring with them. And I have unconditional positive regard for them, no matter what they bring. And I think as educators, one of the things that we have to help our students with is that notion that of unconditional positive regard.
You are absolutely right. And I hear the unconditional regard. Perfect. I'm gonna ask you a question. Okay.
Yep.
Say you know someone who is using illegal substances every day. What would you call that person? I'm putting you on the spot, Barb. Sorry.
Oh, no, that's okay. A person with an addiction disorder.
Perfect. Good.
Yeah.
And because this group knows and they're knowledgeable, but even my staff, I have to get them to change their language because then you have just given them the name of their disease, which is good, rather than saying that you are an addict, because you're not. You are absolutely right. And that's the whole purpose that I wanted to be able to bring to this group today. The biggest stigma that is our language. And we, the media, will, as you said, as even Hope said, that the way the media per se, the headline news, Baltimore is the biggest addict place in the world. That was just in the New York Times last week. Baltimore
I saw that story.
Yes. I mean, it was just amazing. And how it's so stigmatizing, even in our media. And so you're all saying the right things, and you're a very knowledgeable group. But I wanted to be able to make sure that the language we're all working on now for harm reduction. Harm reduction, what does that mean? There's 5 elements of the harm reduction that we're using here in Maryland, and stigmatizing language is one of the top 5. So thank you for that. And so we're going to talk a little bit about language. And Kathy, I love your slide, the power of communication. I kept that slide in here because it's so powerful. This was on a template slide. And I just want to, I like this little slide too, because if you want to care for something, you call it a flower. If you want to kill it, you call it a weed. So that's what I want you to understand, that if we call our patient an addict, we've called them a weed and we've killed them. Okay, so we're going to go over some of that language and a little bit more about how we words that we as providers and talking to the media and getting people to change. This is just 3 little quick slides. People don't understand anymore. Like, why can't I call that patient an addict or a user, or even a substance use drug user, a junkie, an alcoholic? These are the no lists. So if this word is in your vocabulary, or you put it in your note, or your staff use it, or your coworker uses any of these words, this is where we need to start from the beginning. So we change that 3,000-year-old BC stigmatizing language, that we actually work on healthy language, because it's what makes a difference. My peer recovery coaches say, well, Marian, I use addict in the street all the time and junkie. No, no, no. You can use that in the street if you want, but when you're in the hospital, you need to speak as a health professional, and that we are doing the patient first language, and we assign that patient their disease, not their problem. Okay, so addict, user, substance use, junkie, alcoholic, we're going to take those out of our vocabulary. Drunk, formal addict, reformed addict, habit abuse. Even the word MAT, we're getting away from that word. MAT stands for medication assisted treatment, and we're moving towards MOUD, medication for opiate use disorder. That's going to take a little bit longer because they just got all the media and all the education into MAT. So it's going to take a little bit longer. Addicted baby, and the other slide's not in here. I'm just putting a slide in here. Sorry, I'm using one. But my favorite one is clean and dirty. So if we have patients and they come in and they've been using, and we do a urinalysis, if we tell that patient their urine's dirty today, we've just given dirty language. And just to prove that, they did a research project. They took 2 vignettes, so these are randomly assigned vignettes describing an individual, with one taking the same vignette and calling the person a substance abuser, and the second one was having a medical diagnosis of having a substance use disorder. And guess what's going to be my next slide? The results are, which one's better? Sorry, where'd the slide go? I'm sorry. The slide I'm missing in here was the study showed clearly the patients who had a substance use disorder were better taken care of, had better case management, and had better outcomes. The people who were given the substance abuser diagnosis were minimalized, didn't follow through, and had very poor outcomes. This research has been proven over and over again, and we just have to remind all of our clinicians, care managers, politicians, people call you up on the phone and want to do an article, make sure we use our good language with our people. And this is what we talked about earlier. Stigma is actually a vicious cycle with addiction. The patients are stereotyped like the frequent flyer in the emergency room. They're given a label. Their expectations is they're not going to make it again. You give them limited opportunity in rehabs. They internalize that, and they feel bad, they feel shame, and they leave and they don't come back, and our overdose goes up. So we have to break that cycle. But not only do we have to break our cycles with ourselves, but like I said to you, we need to train our staff and anybody else that's around us. Your assessment and your practices, even putting into policies and procedures how to be able to communicate appropriately with your patients, and not just in your environment. Like I said, out in the community, be on advisory boards, policies and advocates, go to events and media. I can't tell you that the person who wrote that New York Times article, I wanted to, we actually called her up and said, it was a Baltimore-based article, but there were so many things that were inappropriate that she said in that article, and there was outdated material. Baltimore has done a lot better in getting their overdose death rates down, but we still have a problem. So I just wanted to show you that there's lots of resources for using the right words, because words matter. What I did is I printed these up and I laminated them, because our Joint Commission says everything has to be laminated. I printed these up and laminated and put them on all the walls in my office, so that it would remind people how to be able to say appropriate language and give them, because people say, well, Marian, if I can't say clean and dirty, what do I say? This gives you the alternative of other languages to talk about. And you as a provider or as a person in clinical scholars who do writing grants or do an education need to be able to go to your dictionary. There's a whole dictionary for addictions that has appropriate languages and other things that you could use instead. And then my favorite is the recovery oriented language guide. So a person with a behavioral health condition or a patient with a diagnosis with substance use disorder is where we need to focus on, rather than the other words that we talked about. So again, I wanted to keep it brief. I wanted to keep it easy and just be impactful for our small group, that I was hoping that we would just do a lot of networking and see what you thought. And because opiate use disorder is just, it's killing our nation. It has decreased the life expectancy. The life expectancy in Baltimore now is 74 for a woman and 65 for a man, mainly because we have had so many deaths in Baltimore that our overall national life expectancy is going down also, and mainly because of opiate use disorder. So we as a nation, and this group specifically, if I teach you here, you're going to take that out to every part of the nation and help have healthy language and help our patients get treatment from the very first minute when you interact with them. So anyway, that's my spiel. What do you think?
Marian, thank you. This is really helpful. One of the things that we're doing, so Indianapolis is on the list as well. With my work in schools with kids and training school social workers and school mental health social workers, one of the things that we do right off the bat is we started learning circles for our students. So they have their classes, and then they also have learning circles, as well as their practicum supervision as well. But in Learning Circle, one of the first things that we do is take them to Overdose Lifeline, which is an organization here in Indianapolis. They all learn to carry naloxone, and they all learn the problem, and immediately, so that when they are in the schools working with parents or working with teens or even middle schoolers, that they're using correct language and making sure that they understand how to assess the situation. But I think it's really important that we begin to use proper language in everything that we do, whether it's with addiction or mental illness or whatever, that we're using person first language. I have 2 doctoral students right now that are working, their doctoral minor is communication, and they're working on ways to improve healthcare through communication. And again, that's extending social work into all the areas. So thank you for this. It's really important work.
Well, thank you. And it's very frustrating. You said when you go into the SAMHSA website or the DEA website, they're so far behind. I have nothing more frustrating than I listened to a lecture, not maybe last summer. The DEA agent got up and talked about being clean and dirty. I'm like, oh, come on, guys. When it goes, so this group knows what to do, but some of the people higher above us, like, come on, get the picture, and they haven't changed their media. either. You go into their websites and you see the language that is stigmatizing there too. So we've got to work on getting it. And I've written them letters, hey, you need to change this. And they go, it's hard to get the website changed. I go, okay. So you're right. We've got to change it not only for us, but for, as I said, globally.
Do you
Yeah.
think the issue has to do with AA and NA? That we're so heavily invested in having folks go to AA or NA, that and they use
That's
that
what I said, my peer
language,
recovery
right?
coaches use that, right?
So I wonder if getting to those groups as quickly as we can with proper language might actually be helpful as well.
And I agree with you. I mean, like I said, my peer recovery coaches, I said,
Yeah.
you may say that out there, but we have to change AA's language because they are part of the recovery that's needed. And if they're stigmatizing, they're very stigmatizing, even to the point where if I have a person who's on methadone, they can't go to a meeting. It's like, really, but we're working on it. But they're hard, but at least they're there for our patients, and we're happy for that. But I try to get my peer recovery coaches to get them when they go to their meetings to speak, get rid of the dirty language, we call it. So yeah.
Marian, this is really great. Thank you so much. I really appreciate the the resources. I'll be like looking into those to like help be able to share in our system. We recently advocated, we have counselors. And so originally their badge said substance abuse counselors.
Mhm.
And like all the like materials and
That's
like
right.
job
That's right.
descriptions, right? So because we have other county departments that have to sort of agree, we landed on substance use counselors. Is there a different recommendation for how we would identify our counselors that are working? That's one question. And I can certainly look through the materials and see if there was or any recommendations, but thought I'd bring it to the group. Also, in terms of, I remember going to one of my law and ethics courses, and I really appreciated the presenter who really said this about the mental health, right? Diagnosis, where people would say like, oh, they're schizophrenic, or right, they're bipolar, and like really making them the thing when it's like, no, person. And so the strategy he had was he would, go through and he would go over maybe some of the symptomatology or some of the things that were distressing about that particular diagnosis. And he would share that with the person. So he wouldn't give them the name of that diagnosis and say, do you experience any of these things? And so they may say like, yeah, like that, I like this happens or I feel this way. And then he'll say, well, you know what? We call that schizophrenia. And right. And so like made it this whole thing of like, you're not that diagnosis. You are experiencing these that you're identifying as challenging and troubling. And this is what we call it. And so really trying to change that. So I really appreciate that, the confirmation of that strategy. And then in terms of stigma, we really have had set kind of varied uptake and buy-in around the naloxone and having
Really?
the kits. Well, right, because I think it's stigma. I think it's there's probably some implicit bias, maybe some explicit. There's like all kinds of things happening for people, and I could see it in the process, right? And so we have some that are like, yes, like we'll keep it, keep the supplies like on hand. So when we're working with someone, we've now added the vending machines to the jail. So when people are getting but then there are some that are just like really not, right? They feel like that means if I'm giving the thing, it's almost like the condom, right? Like if I give
That's
the
right.
condom to the kid, like they're
The
gonna have
birth
sex or
control.
whatever, right? Like,
Right.
and so this whole thing.
Yeah.
And so anyway, I just appreciated that. Like we still are in this place of, even with all the information, where we're just and the health system is like supportive, but also like a little dances around, you know what I mean? Like there's still not this like directive, so to speak. It's a little bit, because I think there's some other things at play, ethical, you know, politic, whatever else is there. So I appreciated the call out of that, because I think it just, for me, is a just a point of awareness to say, like, where are we, and then where do we want to be, and how do we get there. But yeah, if you have thoughts around the substance, you like the sort of the name badge, or like how we're identifying our counselors. If otherwise, I'll just look at the information too.
But for our name badges at my hospital, we just put counselor. I didn't say any particular counselor, right?
Okay.
Because we needed to get away from that.
Okay.
We changed ours to the chemical dependency service.
Okay.
But our associate hospital down the street, University, where the shock trauma is, they still had the substance use disorder, and they don't, they call it the substance abuse consultative service. I'm going, and this is Dr. Eric Weinthrope. You know Eric, right? I'm going, Eric, change it. Well, it's too hard because you got to change. It's a mammoth to change a name in an Epic computer system, a health system. He said, I don't care what you call it, just as long as my patients get it. But Eric, why are you the substance abuse consultative service? You know, so it's hard to change things that are in people's minds. And to that effect, I said, I did a lecture yesterday, you know, with buprenorphine, that's what's going to save our country, believe it or not. It is a medication to help treat this disease of addiction. We used to have the waiver. A provider had to go and get the X waiver in order to write. That's all gone now. They're trying to break down all those barriers. So I'm trying to teach people that to normalize the addiction disease. Why are you so afraid of prescribing medication for a patient who have an addiction? You don't worry about giving them hydrochlorothiazide for their blood pressure or insulin for their diabetes. Why would you be afraid to give buprenorphine for the disease of addiction? And they're like, duh, I thought you had to get counseling and had to do this urine. And no, you have to have good practice, but I'm trying to normalize addiction. It's just another disease in your problem list. And that's where we need everybody to get to, that it's here, it's everywhere. If you don't see it, it's because you're not looking. It's in your family, it's in your church, it's in your school, it's in your nurses, it's everywhere. And if we've got to open our eyes and treat it like we do every other disease, in my opinion. So on that happy note, thank you for appreciating. I thought this would be kind of boring for you, but you're very enthusiastic about listening to how we can save lives with stigma in many ways, not just addiction.
I'm looking forward to taking this to my students, so thank you.
Oh, good.
Thank you so much, Marian. That was excellent. Really a nice update. I have a quick question about what do we know of how we're using these words in the impact of this change? Do we have any studies ongoing that are emphasizing like when we do, you know, go through this this shift, and we're actually able to get leadership to buy in and to take the time and the money and the resources to update certain things when that actually does happen. How impactful is this? Are we at that point yet?
I don't know of any updated studies. The study that I did present just now was the vignettes between the substance abuser and the patient with a substance use disorder is still very relevant today, but they would have to recreate that particular study, I think, and maybe use different terminology. For me, it's impactful by the amount. Let me give you a story. Always tell me, we started putting peer recovery coaches in the emergency room, right? And we put peer recovery coaches in the emergency room, and the goal was to decrease recidivism, you know, decrease the patients coming back and forth to the emergency room. That was the goal. What happened when we got peer recovery coaches in the emergency room? The recidivism or the revisits went up astronomical. Okay, why? Because the peer recovery coaches didn't have stigma, you come back anytime, come back as many times as you want. Okay. We are here for you. You didn't get it last time. You didn't get it this time. You're going to get it next time. It's okay. So the number of people that came back to the emergency room over and over again went up, and the hospital was having freaking out. And I go, no, look at it the other way. They were welcomed to come back again. So in answer to your question, Hope, I'm not sure how you measure that so much, except that if you get the patients in, so now we are measuring our buy-in to how many patients come back. We follow them up with phone calls by the peer recovery coaches. And there's a difference between a referral and a linkage. A referral is you just say, here, go see Marian tomorrow. The linkage is, did you go see Marian? And verify that the patient did come in and meet Marian. So our way of researching the openness and the anti-stigma and the availability of treatment is there. I'm not sure if that answers your question, but it's a step in the right direction of how we're measuring the openness and the breaking down the stigma in the language with the help of the peer recovery coaches.
Sure. And I think, yes, you definitely answered my question. And it would be interesting if some publications could start to evolve just using those narrative stories like what you just provided to help with the movement. I don't really like the word movement, but just
the trend towards healthy
yeah,
speaking.
trying to get more people to identify how impactful it could be. So thank you so much. And I also wanted just to do a shout out to everyone about our Chicago Summit. Don't forget to register. It's coming August 5th through the